A very good morning to our highly motivated audience. First of all, I thank my colleague Dr. Ghulam Ali for nicely illustrating the status of the disability and the various principles which we can use for treating such patients. So first of all, sorry. So how do we assess this situation basically? So our aim is to identify the person's visual needs and goals. So first of all, the most important emphasis is on the detailed and extensive history. Okay, so this needs to be taken care of in high detail, because uh, before prescribing any low vision device, this is very important to understand the patient needs and with which device he'll be most benefited. Like, so low vision examination begins with chief complaint, any current problem is being treated for, and any other physical disability which might hamper the use of certain devices, like tremors and arthritis are few of the conditions where we cannot give them the handheld devices. And clinical examination including fundus evaluation is very important in such condition, because it helps us to assess the fixation, whether it is central or eccentric, because this is very important. And coming to the visual acuity assessment, when we want to assess the distance visual acuity, the preferred charts are logmar charts. But in cases of unavailability, we can do visual acuity assessment with the Snellen chart also. And if the visual acuity is less than 660, so we need to bring the patient closer to the chart rather than reporting the visual acuity as finger counting, because neither it is standard nor it is accurate. And the other very important aspect is patient feels quite depressed whenever he is unable to read the charts. So they feel better when they are able to read few lines. And near visual acuity assessment, the main aim of near visual acuity assessment is to understand how they cope up in their daily tasks, like personal care, hygiene, eating, cooking, reading, etc., etc. Because the main aim is to improve the quality of the life for such patients rather than giving them a prescription. This is more important. So we have to ask about other factors also, like whether he is able to read normal newspaper prints or the large prints, or what is the reading speed for them. Do they feel fatigue for reading for longer periods? This has to be taken care of. We also need to assess their literacy level, because if the patient is illiterate, then we have to prescribe different devices, because their needs are quite different than the literate ones. Like if the patient is illiterate and then he became blind, then they are very easy to shift to the braille, but it is not the other way around. And when we talk about refraction, the retinoscopy is very important. Okay, so if retinoscopy is not available or we are not able to do the retinoscopy, autorefs can also be used. And also where autorefs are not available, we can use the old prescriptions as a guide. They also help when we prescribe then the new prescription, because if we compare the old prescription with the new prescription and there is not much subjective improvement, then it is not a good idea to prescribe a new device or new glasses. Keratometry can also be done in assessing refraction. Visual fields, it is very important, because if a patient is having central scotoma, we have to see the presence and its size. Because if, for example, like larger the scotoma, higher the magnification patient requires than the usual ones. And we also have to see the peripheral visual field loss, because such patients require few additional devices or few irregular ones, like which are not usually prescribed, like dome magnifiers are more helpful in such patients where the visual fields are severely constricted. And we should not miss the contrast sensitivity, glare, stereopsis like parameters, because these problems adds lot to the patient's disability. Like if a patient is having reduced contrast sensitivity, he might be having lot of difficulties in day-to-day tasks like pouring milk in a white cup, or they experience difficulty in reading past books, like where the prints are not so dark. And such patients require few additional things, few non-visual devices along with the usual visual devices, like there may be a need of higher illumination or the typoscopes, such devices. Glare is another problem which adds to a lot of their problems. A very simple test to assess glare disability is to use the visual acuity charts with and without illumination. If the patient feels better with illuminated charts, or there is decrease in the visual acuity with illuminated chart, then that means the patient is having glare disability. So here we have to adjust the illumination conditions, or we need to add absorptive filters along with the prescriptions. Color vision should be noted, stereopsis should also be assessed. And one more important thing, we also need to do the binocularity evaluation, like whether patient is binocular or they have only uniocular vision, because few devices are based on the availability of the patient to see binocularly. And we also need to ask for the previous use of any LVA, low vision devices, how comfortable they were with these devices, or were they feeling better. Also we should see for the oculomotor skills like tracking and scanning, because they play an important role in daily mobility and the daily activities of the patient. One should also ask for the performance of the patient in various lighting conditions, whether he feels photophobia, is it mild, moderate or severe, or is he requires additional light or normal illumination in the indoors, whether he feels extra difficulty in the night time. These are the few important points we should ask in the history, along with the usual and regular clinical evaluation. So here is the example of our low vision clinics sheet, where in this patient with nystagmus and secondary optic atrophy, the distance vision is not improved, but with the near vision correction, the near visual acuity improved from N36 to N12. So we prescribed these near vision devices, low vision devices for him. And in one of the studies conducted by our chief instructor, this is the usual workflow which we follow in our clinic. A patient is first identified in the low vision as low vision, and then he's sent to low vision service chief for ophthalmic workup, and then to optometrist for low vision workup and prescription. And along with that, ophthalmic assistant is also posted for the training purposes. And then patient is followed up every 6 months to see for his routine, how he is improving or how he is adapting with the low vision device. So here we'll take a rest and we'll summarize what the situation is before moving on to our next presentation, that is what do we have with us. So after assessing, we will have a look at our armamentarium to fight this long battle. So here is the list of all the weaponry we have, which can be classified as optical aids and non-optical aids and non-visual devices. Okay, can have a photograph of this list if you want. The basic principle of LVAs is to magnify, thereby increasing the retinal spread of the images. So these are few types of magnifications, or we use a single type or the combination of these types of magnification in various low vision devices. The object magnification means the simply enlargement of the size of the object. There is no optical system as such, because it makes the object bigger to the visual acuity levels which the patient have. The other one is approach magnification or relative distance magnification. It is achieved by simply moving the object towards a person so that it subtends a larger image on the retina. Few optical systems like hand magnifiers, stand magnifiers use this principle. And angular magnification is the apparent change in the size of the object rather than the actual size of the object. So telescopes usually work on this principle. So there are few limitations with this magnification, because higher magnification leads to smaller field of vision, closer working distance, and reduced depth of field. For example, 3x telescope will have 12.5 degree field of vision, and 4x have reduced field of vision to 10 degrees. So the selection of device will thus depend on these factors and not simply on the level of magnification targeted. For distance vision, we have telescopes which can be handheld or spectacle mounted. These have a small but very important role in low vision patients. These are generally used for activities like reading signs or blackboard in school in cases of kids, traffic signals, or even watching TV. So there are two basic designs based on the principle of angular magnification, Galilean and the Keplerian one. Although the Galilean one is smaller, but the Keplerian one provides higher magnification and larger field of view. So the advantage is this is the only optical device which enhances distance vision, and they lead to dramatic visual improvement, but they come with lots of limitations. As I've already mentioned, that they have very limited field of view. Cosmetically, they are not very acceptable because they make the disability more conspicuous when they are using it. And also they are not very cheap as compared to the magnifiers which are used for the near vision. So in this study conducted by our chief instructor is showing the improvement of visual acuity from 162 up to 624. So magnifiers are actually plus lenses that are handheld and used in spectacle plane. They can be used with or without glasses, and they are given for short-term near tasks because they have the problem of increasing fatigue with prolonged usage. Short-term tasks like reading labels, price tags, identifying money, etc., etc. They can be self-illuminated also, which improve contrast. So patients having reduced contrast sensitivity can be given the illuminated ones. Best part of these is low cost and easy availability, and they also work in patients with eccentric vision where the central scotoma is very big, but they are not hands-free and have limited field of vision as usual, and not for patients with physical disabilities like tremors, arthritis, etc. So to overcome these limitations, we have stent magnifiers, and they are also very important in patients with reduced fields. They can also be self-illuminated types. We also have spectacle magnifiers, also known as high plus reading glasses. They are very useful in patients having binocularity. Base-in prisms are added to compensate for the convergence angle. This we have to think very clearly before prescribing these glasses. And they can be of full frame or the half frame types, and these are cosmetically more acceptable because they make the disability less conspicuous and have the biggest advantage of largest field of view. So this is the same study showing the visual acuity improvement up to N6, and this is an example of an only eyed patient with advanced glaucoma in the seeing eye benefiting from the high plus reading glasses, and these can be used for monoocular and the binocular purposes. There are few other examples which can be tailored to patients' need, like dome magnifier for those with constricted visual fields, Fresnel lens magnifiers, magnifier ruler or bar, and they have the advantage of offering binocular vision, and they can be used in addition to these spectacles. CCTV is another useful device which uses electronic magnification for the magnification purposes, and it provides magnification up to 40x, which is not possible with any other device. And they also have a very big advantage of reverse polarity. That means the white letters on the black background. So few patients actually benefit from this, but the only problem with this is the high cost and the not so easy availability. And we also have inbuilt tools in Microsoft Office or commercially available softwares like Zoom Text or Fusion for computer users. These enlarges the image also and reads the documents, mails and web pages where patients are severely disabled. And now everyone uses smartphone. So this in itself is a versatile low vision devices because it has many settings like large text, zooming, camera can be used as a magnifier, and it has digital assistant now which eliminates the need of reading and typing. Few cell phone apps, probably if one have attended the previous session, there was mention of these apps like Seeing AI. It offers multiple channels that identifies short text, pupil, products and more. And for low vision users, the short text feature is a dream come true. Just point the phone at text and it instantly starts reading, including handwriting. It identifies handwriting. That is the biggest advantage. And Soundscape is another such app. It can be called as a map with 3D sound. This integrates GPS technology to give visually impaired enhanced information. It's a bit like a strolling with your friend who tells you about the surroundings. Now we have this particular landscape or this landmark. So, and look out, be my eyes. There are so many apps coming up now to help such patients. And along with that, we can enlarge the text, and it can be used in many devices like textbooks, phone dials, watch dials, calculators, remotes, which can help such patients. And few other devices which can be used in day-to-day life like Notex, which helps in identifying notes, typoscope, as I've already mentioned, writing and signature guides, talking watches, even needle threader. Another device is sonic canes. Usually we have simple canes which helps in moving them here and there, but sonic canes actually come with a supersonic sensor capable of detecting obstacles in the range of about 25 degrees in the horizontal region and about 50 degrees in the vertical range. And this system causes the cane to vibrate when some obstacles come in their upcoming path. So if we are planning to establish a low vision aid with minimal of resources, we should have these three devices with us, that is telescope, hand magnifiers and the half frame prism glasses. If not anything else, you should have these three glasses.